All right, we're going to go ahead and get started. Hello, everyone. I'm Vincent Atchity, President and CEO of Mental Health Colorado.
And I'm Emma Troughton, Communications Manager for Mental Health Colorado.
Thank you all so much for joining our virtual conference series on women's well-being. This free conference has been offering 60-minute afternoon presentations and discussion from Tuesday through Friday of this week. Experts by experience, advocates, practitioners, and others have been addressing and discussing some of the unique mental health experiences faced by women and other people of marginalized genders.
Thank you all for joining us today in acknowledgement that women's rights are a mental health matter. Please invite your colleagues and allies to join us this week. And please know that each of this week's summits are being recorded and will be made available on our website indefinitely.
On day one, our presenters spoke about eating disorders, weight stigma, mental health treatment equity, and vulnerability in brain health. On Wednesday, our presenters spoke about criminal justice and empowerment, in addition to perinatal well-being and environmental and social supports during pregnancy and postpartum. Yesterday, we heard about intimate partner violence prevention and about working moms and burnout. And today, we're going to hear about sexual assault prevention and perinatal violence prevention.
Before we get started, we want to thank our colleagues at Mental Health Colorado for all their efforts in making this series possible.
Thanks again to all our presenters and participants for joining us this week. Please know that our advocacy and education work is possible thanks to the generosity of our partners and allies, and we thank you for your donations. In this historical moment of persistent and emergent violence on women's rights and personhood globally and domestically, from Iran to the US Supreme Court, we aim to promote more holistic comprehension of women's mental health needs in the interest of advancing well-being and empowerment, especially in anticipation of the midterm elections.
If you haven't registered to vote, please do so without delay by following the link that we'll post in the chat, and make sure your voice is heard.
As you listen to our speakers today, please use the Q&A function to ask any questions. We'll have a few minutes for questions after our final speaker of the day and the series. And with that, it's my great pleasure to introduce our first speaker before I go off screen to listen attentively. Thank you so much. We're happy to welcome Megan Carvajal, who's the Executive Director of the Blue Bench, who will be speaking with us about sexual assault prevention. Thank you, Megan.
Awesome.
It's all yours.
Thanks, Vincent. Hi, everyone. It is a pleasure to be here with you today. It's always strange to say that when we're talking about issues of sexual violence, but truly it is always an honor to get to advocate on behalf of survivors in any space that I'm welcome. So thank you for inviting me. I don't have a formal presentation today. I am a conversationalist and I welcome your questions. I will also say up front, I'm not looking at any chat functions. So if there are any questions in the room, I will do my best to pay attention to that. And then lastly, I'm going to pop real quick. If I can in the chat, I'm going to add Vincent, our hotline number. I will mention it in a minute, but want to make sure it's accessible to everyone. Thank you. So like I said, I'm Megan Carvajal. I'm the Executive Director of the Blue Bench. And I want to start with a few disclosures. So I want to recognize first that the statistical likelihood that many of you have identify as a survivor of sexual violence is true. You are here with us, and some things that I say might feel triggering to you. So if that is the case, please take care of yourself and let us know if you need something from us. Please feel free to step away, take some deep breaths, take a drink of water. And if you feel in this moment that you need support, our hotline is open right now. It's open 24/7. You can leave this room and call that number right away that I just put in the chat. I'll also disclose I'm not a social worker or a clinician. So if you have specific questions in those areas, I am happy to follow up and or connect you with someone from our team who can reach out. I'm also considered a mandatory reporter. So if a minor were to disclose anything today, or if as an adult you disclose the assault of a minor, I may have to follow a protocol to report. Okay, so a little bit about me. I've been with the Blue Bench for nearly 2 years. I, for the last 25 years, have been a nonprofit executive, operations professional, fundraiser in Austin, Texas. And so I have only been here the 2 years that I have been with the Blue Bench, but I absolutely love being a Coloradoan. I identify as a queer white female. My pronouns are she, her. I also welcome they, them. And I'm a mom, I'm a wife, and I'm a survivor of sexual violence. I came to the Blue Bench because I believe in this mission, I believe in this work, and I really want to live into my core belief that we can do something bigger together than we can on our own. So at the Blue Bench, our mission is to support survivors through therapy, case management, and victim support services, and as well as empower youth and adults to end sexual violence through comprehensive prevention education programming. We believe, we know that it's important to show up where sexual violence exists, and that's anywhere, where we learn, where we work, worship, where we play, and even where we live. The Blue Bench provides services for all folks of all identities that experience sexual violence. And we hold true to the statement that consent is mandatory. And we like to explain consent as it's not the absence of no, but it is the enthusiastic presence of a yes. Sexual violence isn't just the word that terrifies us the most, and I will only say it once: rape. Sexual violence can also be unwanted sexual advances. It can be intimate partner violence, and it can be harassment in a variety of places and spaces that we're in, at school, at work, when you're out at a bar or a dance club, and especially in online communities. To end sexual violence in Metro Denver, we have to work, the Blue Bench has to work with other organizations and institutions to address the systems level barriers that also exist. So we partner with law enforcement, with district attorneys' offices, judicial districts, family justice centers. We are in schools, and we are working with other community partners so that we can align our work and hold accountability to each other for being survivor-centered and trauma-informed. I would love to share some statistics with you, but I'm just going to check in real quick and see, are there any questions right now? Okay. So let me share some statistics. In Colorado, 1 in 3 women will experience an attempted or completed sexual assault in their lifetime. 1 in 2 transgenders will have that experience, transgender individuals will have that experience, and 1 in 6 men will experience that as well, and a completed or attempted sexual assault in their lifetime. It is also important to note that less than 30% of assaults are actually reported. And of those, 90 to 98% of sexual assault reports are true. We know that media plays into this factor in these statistics that are so important. When we see through social media avenues, news media, accusations of reports being true, thanks to RAIN, the national network, focusing on this issue, we know that statistically 90 to 98% of those assaults reported are true. I want to share some risk factors. So both intimate partner and sexual violence risk factors can include lower levels of education. And that we would think about that as like individuals who don't complete high school or don't have access to the education that allows them to graduate from high school or get their GED. A history of exposure to child maltreatment. So if we experience mistreatment, neglect, abuse as children, we might have a higher risk factor for experiencing sexual assault. The same is true for individuals witnessing family violence, individuals who have an antisocial personality disorder, individuals who have harmful use of drugs and alcohol, harmful masculine behaviors. So perpetrators who have multiple partners or attitudes that condone violence. Community norms that privilege or ascribe to higher status to men and a lower status to women. Lower levels of women's access to paid employment and low levels of gender equality in the workplace. Women with a disability are more likely than women without a disability to report experiencing an assault that is outside of sexual violence, including physical violence, stalking, psychological aggression, and control of reproductive or sexual health by their intimate partner. And then men with a disability are also more likely than men without a disability to report experiencing violence, especially stalking and psychological aggression by an intimate partner. It's really also important to note that sexual violence starts early. More than 4 in 5 female survivors reported that they were first assaulted before the age of 25, and almost half were assaulted as a minor, which is before the age of 18. Nearly 8 in 10 male survivors reported that they were forced to perform a sexual act before the age of 25, and 4 in 10 were first forced as a minor. Sexual violence also disproportionately affects some groups. There's intersectionality of violence against women. Women in racial and ethnic minority groups experience a higher burden of sexual violence. For example, 2 in 5 non-Hispanic American Indians and Alaska Natives and non-Hispanic multiracial women were assaulted in their lifetime. That's 2 in 5. And then the last statistic that I'll share is that in the last year, specifically at the Blue Bench, 90% of individuals who received services at the Blue Bench identified as female. No questions yet. Thank you. So here's how we help. At the Blue Bench, we exist for survivors, and we show up for that in 3 main ways. Through therapy. This is a critical step in the healing journey, and we offer individual and group therapy services. We also offer workshops, specifically a workshop called Someone I Love that is for loved ones of survivors. That secondary trauma is also really important in a survivor's journey. So getting their support system helping them understand what has happened and how to support the survivor in their life is really critical. All of our therapists are our staff. They are part of our team. They work full-time with us, and they receive extensive training and continuing education on trauma-informed, survivor-centered practices, and they use a variety of modalities to support their clients. We also provide case management services. As a survivor, navigating a system that works against us is exhausting. So it's important to have that victim advocate there to help us navigate what we are going through, whether we decide to report to law enforcement. So navigating law enforcement and legal systems. Survivors may experience loss of housing. They may lose their ability to have their own transportation. They may need additional medical care. So our victim advocates are there to help them figure out those systems and access the support that they need. A good example of this is we recently were awarded a grant of sorts through the state that has access to flexible funds that can be used to help remove the financial barriers that often exist when a survivor experiences an assault. So we are able to support victims directly with financial assistance for housing, transportation, and basic needs. We also do a lot of resource and referrals. So someone who may have experienced an assault a long time ago and doesn't necessarily need therapy or case management right now, but may just want other supporting services like educational needs, being connected to medical providers in our community that address the secondary needs from an assault. We have a team dedicated to making sure that survivors can access the resources that they need in a timely manner. And then prevention and consent education is critical. It is critical to us ending sexual violence in Metro Denver. So we focus on empowering youth to understand consent, to recognize inappropriate behavior, and to be a good bystander. Those are critical to creating that community of preventing sexual violence, but also, especially when we're working with youth, I would say 90% of our prevention education happens in schools, middle and high schools, and sometimes college level universities. We're also giving kiddos the knowledge that they need to say no, and to feel safe accessing services should something unthinkable happen to them. So we are empowering them and giving them the support that they need as well. I want you to know that if you've experienced an assault in your lifetime, whether it was a week ago or 10 years ago, we believe you and we're here for you. And you can start by calling that hotline. It's confidential and it's available 24/7. There's no commitment to report when you call. We're just here to meet you where you're at, be a listening ear and validate your experience. We can also talk to you about taking next steps. We can just sit there and listen and not talk. And if your assault is immediate, we're here to support you if you choose to go to the hospital and have an exam conducted. We provide volunteers and on-call staff to show up at a hospital with you, and we will hold your hand and support you through that experience. We know that sexual violence does not discriminate, even though there are communities and populations that are more aggressively affected. Anyone could experience a sexual assault. And so we want you to not only have that hotline number for yourself, but we want you to put it in your phone, because you never know when you might need it for someone else. You might be the most trusted and safe space for someone. And when they're with you, they might choose to disclose. There is no rhyme or reason to when we choose to disclose. It sometimes just happens. So have that number available in your phone. Let the person who's disclosing to you know that you believe them, and take this knowledge that I'm sharing with you, and in your own words, create that safe space to share that with the person who you're speaking with. I will also offer that as professionals in the work that we do, we all want tools available 24/7. We want not just a number, but we want something physical to hand over. So as a participant in today's discussion, if you would like a stack of hotline cards or how we can help cards available to in your workplace, to have in your car, I always have like a stack of cards in my car and in my purse. We'll send those to you. So if you would like to have those handy, you can send me an email and I'll pop that link, that email address in the chat. We'll mail them to you, or we'll have them available if you want to come pick them up. And that's it. That's what I have to share today. I would love to hear from any of you if you have questions. And again, if I can't answer them, I will follow up. Thank you so much.
Thank you so much, Megan.
Yeah.
Maybe repeat the hotline number.
Yeah, absolutely. The hotline number is 303-322-7273. Our website is thebluebench.org. We also have a 24/7 hotline in Spanish. So if you work with Spanish-speaking populations, both of those numbers are available at the very top of our website. It's the first thing that you see. We have materials available in Spanish. So if you would like this information presented in Spanish to Spanish-speaking groups, we do have staff available who can do that as well.
And we do have a question in the chat, and that is, does the Blue Bench work with or connect individuals to peer supporters?
Oh, that's a great question. Peer support from a volunteer standpoint, the short answer is yes, in terms of in the way of our hotline. So that is direct peer support. We do not have a peer support matching program. But our advocates do often operate as peers. And if you have ideas on how the Blue Bench might provide a peer level support program, or if you work in a program that you feel like that model might work for us, I would love to have that conversation. Oh, Vincent, you're on mute.
Thanks. Another question that's appeared is, what are some common challenges faced when it comes to helping victims navigate the criminal legal system?
Oh, if you've had to navigate that system at all, you know that there are so many answers to that. When you are having to navigate with law enforcement, there are very critical, direct steps that they have to take that we all understand are barriers for survivors seeking justice. So there has to be a lot of claims that have to be substantiated. The best way that they can substantiate is DNA. That is a very unlikely way to substantiate an assault, but it is also still critical to navigating that legal system. Quite frankly, the hardest thing is just for a survivor to hear, we believe you, and we are going to advocate on your behalf. Professionals have different ways of explaining what that means. And so that is why it is so important to have an advocate when you are trying to navigate the system, because we have the words that survivors don't have that allow barriers to be broken down within law enforcement and legal systems.
Great, thank you.
Yeah, thank you.
And then, just another question.
Mhm.
So if survivors of sexual violence choose not to report, what are some ways potentially that they could seek the feeling of justice?
That is such a good question. We do not require or even encourage people to report because it is an individual decision. We give you all of the information that you need to make that informed decision, but it is not our job to sway you one way or the other. So the ways that survivors seek justice when they don't file and seek justice through the criminal system is being supported on their own journey. So sometimes justice can look like completing 6 months of therapy and in setting those goals with your therapist and looking at those outcomes 6 months later. You can feel a real sense of justice just internally. It can look like regaining housing. It can look like regaining some autonomy outside of a relationship. Intimate partner violence is especially important here because we have reliance on someone else. And when we feel like we can be autonomous ourselves and own our own selves and navigate life without the reliance on someone else, that can feel like justice. For survivors, it's different for everyone. And that's why therapy especially can be helpful because you determine what justice could look like for you.
Awesome. Thank you so much.
Yeah, thank you.
Cool. Vincent, do you see any other questions or?
No, I don't. Not right now.
Okay, good.
Thank you so much, Megan.
Yeah.
Thank you so much for the work that you do.
Thank you. Thanks for giving us a platform to talk about this. This is the way we end sexual violence. We talk about the hard things, we say the things no one wants to hear, and we sit with that level of uncomfortableness together and make a plan to move forward. So this is my favorite thing to do because I know that everything that you hear today is going to resonate with you. Something I said is going to sit with you for a long time. And all I ask is that you do something with it. Help us become a part of a community that is solving this and not that is perpetuating this.
Thank you so much for joining us.
Absolutely. It's my pleasure.
So next, we're going to introduce our final speaker for the day and our series. And thank you so much to Qing Li, MD, DrPH, clinical scientist with the School of Nursing at the University of Mississippi Medical Center. Thank you so much for joining us, Dr. Li, and for speaking with us about perinatal violence prevention. It's a pleasure to have you with us.
Hello, good afternoon. Can you hear me? I want to share my screen. Can you see my screen?
Yep.
Yes.
Thank you. So my name is Qing Li, Qing, sounds like CHING, LI, Li. I'm so grateful when invite me to this forum. I listened to Wen's outstanding closed keynote in a 2-day workshop on managing mental health in primary care. So today I will present preventing perinatal violence among adolescents or Latinx mothers. So I observed couples when I was delivering baby in Guangzhou, China. At that time, there was no epidural. So I need to find a way to encourage the husband to support the mother to go through the process without epidural. And I also trained obstetrician gynecologist in a World Bank funded project in China. I came to the University of Alabama, Birmingham for my Doctor of Public Health program in maternal child health from Maternal Child Health Bureau funded a leadership program on interdisciplinary approach to maternal child health. I have been a clinician scientist adjunct with school nursing, University of Mississippi Medical Center, Jackson. The reason I'm in Colorado because I relocated to Colorado after my husband started his dream job in University of Colorado School of Medicine, renal division as a statistician 6 years ago. In the remaining about 20 several minutes, I would like to give a brief introduction and highlight needs and the significance of this topic in Colorado. Find the time to talk two or one research project and end with future study. So the definition and topology of violence, here I highlight is the intentional use of physical force and power. So including threatened or actual against oneself, like suicide behavior, another person, like child maltreatment or intimate partner violence, or against a group of communities, including physical, sexual, psychological violence, deprivation, or neglect. Violence risks cross the lifespan and the generation. So we will talk about both dating violence and the intimate partner violence. Why this topic important for Colorado? Let's look at maternal mortality rate data. In Colorado, counts of pregnancy-associated deaths continue to rise. From 2014 to 2016, 94 mothers died. There are significant racial ethnic disparities persistent, with Native American and Asian American mothers ranked as the top two. So 5 Native American mothers' deaths over 2,000 births, live births. So the rate, maternal mortality ratio, were 4.6 times of the state average. For Asian American mothers, it was 1.6 times of the state average. The top causes were behavior related: suicide, drug overdose, injury, homicide. Half of 8 homicide cases in Colorado in that 3 years were committed by male partners. DrPH this morning provided me the new data from including 2014 to 2018. So I will study those further to generate some publication. Here I show you using national data set, National Violence Death Reporting System. 36 states, we look at pregnancy-associated homicide cases. The majority were preceded by firearm use, more than 70%, or IPV, about half of those homicide cases. in those 3 years. And the joint firearm use or IPV were about 30 several percent. Compared to this number, only very small minority were preceded by mental health problems or substance use. So the urgent need to address IPV and firearm use among pregnancy-associated homicide cases in the country. So this is about surveillance data. Meanwhile, we also need to pay attention to early prevention. I will talk with you about a study data set I have been analyzing. The third public manuscript from that data, we look at perinatal depression, self-harm ideation, and substance use together. How the intervention program prevent those 3 outcomes in order to design violence-related maternal early warning systems and reduce maternal morbidity and mortality. So I submitted those for conference presentation. The last one was presented this week at NIH. I'd like to draw your attention to the National Center for Injury Prevention Delta funding. So in the past 20 years, this injury center from CDC funded 3 cohorts, 14 states in 2002. Those dark color, the states, and 19 states since 2007. Delta PrEP, those light purple color. And in 2013 to 2018, 10 states were founded. However, I want to draw your attention to those deserts. The 6 states, including Colorado, haven't been founded in the past 20 years. And the 4 states here, including Mississippi, haven't been founded. Right now, CDC has a funding competition due the end of November. I hope someone in Colorado would like to write a proposal. Please contact me. I'd like to help this institution to apply for this funding. When we look at healthy birth outcome and maternal well-being, a life course perspective has been a key framework to guide my own research. So Michael Liu and Neil Hoffman in 2003 published this important review on racial ethnic disparity in birth outcomes, a life course perspective. So those disparities between Caucasian and African-American mothers, their birth outcomes were quite different, and those related risk factor and protective factors were highlighted here. If we can find a way to reduce those risk factors and promote those protective factors, we may narrow those disparities. However, this life course perspective suggests we need to look at both during pregnancy and also even when the mother was during pregnancy. So there is an intergenerational perspective in this framework. Since we are in Colorado, I'd like to introduce you this landmark multidisciplinary study published in 1962 in JAMA. So Henry Qing and Brandon Steele in a multidisciplinary team published the Battered Children Syndrome. A more important study run by Dr. Qing, I highlight here in 1977, his team designed a randomized control trial to prevent child maltreatment. And in their intervention strategies include pediatric and community intervention. So pediatricians work with home visitors and in the community as a team to prevent child maltreatment effectively in Colorado. However, 45 years later, this landmark study intervention trial was only cited 350 times. I wrote this commentary with mentor Wayne Pelosi and Dick Cookman. We plan to submit to Pediatric as a commentary. I want to draw your attention. In 1976, Kemp already highlighted the importance of bonding to design this important trial and the pediatrician's role to assess emotional health of families. Henry Kemp and helped a colleague in Alaska. He went to Alaska and helped another couple in private practice, pediatrician George Brown and his obstetrician wife, Carolyn Brown. They carried Kemp's approach, engage father and the partner early in the pregnancy, assess and address red flags, including intimate partner violence, alcohol abuse in their community, and also train layperson as a home visitor. So they document their findings in their publication. In 2000, Eric Ting reported the importance to address IPV to achieve better effectiveness on reducing child maltreatment. And this couple, Brown couple, in their private practice, had performed their study much earlier, about 20 years earlier. So this is an important legacy we learned, need to continue. Think about how we effectively prevent child maltreatment in Colorado. Here I want to show you this video from Lisa Berkman and Glass. We are thinking about maternal well-being, and she is in a complex system. So her behaviors, including alcohol use, self-harm, and her depression, anxiety, those psychological pathways, and her self-efficacy to be an effective person to manage her life and manage the household have been the pathway you can see on the left-hand side, in the right-hand side. Meanwhile, we move a little bit further. The psychosocial mechanisms include social support discussed in this week, and also the role of intimate partner violence can be assessed as intimate contact, the behavior. Meanwhile, the importance of the couple's support, the male and the female couple or their same-sex couple, their form a social network, their intimacy, their duration of the relationship, their tie have been important as the support to healthy pregnancy to overcome those deficits from pregnancy alone. Meanwhile, the upstream factors like social structure conditions, the culture, social economic factors, politics, social change such as COVID, and all important and shape those individual behaviors and the couple's behavior down the road. So you always think about this conceptual framework. In my dissertation, it was a big baby step in the Deep South, Birmingham, Alabama. I highlight this key measurement. So in the household level, we measured lack of involvement among partners, being unmarried, being in an uncommitted relationship were those significant risk factors of IPV during pregnancy. Here is another graphic way to show you the role of those measures here. When I adjusted for neighborhood context, also individual factors such as race, ethnicity, education level. I want to draw your attention to this concept because this is those measurements allow us to think about social bonds and informal social control from Travis Hersey, this scientist from criminal justice. In his 1969 monograph, he published those important concepts here. We followed several schools of scholars worked on this, built this literature. So Hersey suggests internalized of accept norms, awareness, sensitivity to needs of others, which promote community in society. Those internalization process protect most of us from violence free. Each dimension of those bonds, commitment, involvement, attachment, belief, tie individual to societal rules, thus informally controlling and preventing deviant behavior, such as IPV. So commitment and involvement were defined here. The degree of dedication to the joint benefit of each partner, their future, the design to maintain the relationship for the long run. So in my dissertation research, I include those sentences. The formation of commitment helps couples adopt realistic goals, come close to fulfilling those goals, which help prevent conflict and IPV. Commitment involvement becomes silent feature among resilient low-income households to achieve positive adaptation in response to adversity, supporting federal initiatives on healthy marriage, promoting responsible fatherhood. So when we look at the new data in the randomized control trial, especially those teen mothers, we think about commitment is invest time and energy on activity to achieve future aspiration for those teen mothers, such as relationship, education, or care, career goals, because lack of vision of commitment and skills to make future-oriented decisions result in teen precocious co-residential union, infidelity and jealousy, and second pregnancy is a root cause of relationship instability and insecurity, often leads to violence. Former one, a scholar in my network for life course intervention research, published papers and books and highlight the key process in family resilience, including belief systems, organizational support, and communication processes. So those 9 specific areas, if using a simple way, I would draw your attention on the concept of social bonding and informal social control, the commitment and involvement. Let's look at the early signs of this. My daughter brings back home her elementary school sentence: "Don't marry someone look cute, but who can cook." And my professor in statistics in China in the WeChat shared with us, if you treat your wife like a king, you are the queen. If you treat your wife like a queen, you are the king. So those things allow us to think about those relationship building and how to express love, when we should do. And when I asked Scott Demi how we can assess those in the population level, he said in big surveys, family psychology already use those simple sentences. How committed are you to your relationship? How committed is your partner to your relationship? Think broadly, resilience is nurtured in relationship. We can build resilience over life course, focusing on belief, practice, and supportive connection. So this is the Waters' book, Strengthening Family Relations. Can we learn this everywhere in the classroom? in kindergarten, in prenatal care visit setting. I hope this important knowledge and practice can be everywhere. In clinic setting, screening IPV has been recommended. And this is the 4 questions in Casa Permanente, Colorado. So Christine was the champion of IPV prevention in KP, Colorado. So within the past year, have your partner or anyone else hit, slapped, kicked, or otherwise physically hurt you? Within the last year, have your partner or anyone else forced you to participate in unwanted sexual activity? Are you free of your partner or someone else? So in KP, Colorado, those providers try to ask every woman in every visit. And in my research, so this is the detailed measure for prenatal abuse assessment screening tool. Clearly identify who are the person, who are the perpetrator, either husband, ex-husband, boyfriend, stranger, or the multiple person. In terms of prevention of IPV, I'd like to draw your attention to the National Center for Injury Prevention Control IPV technique package, including 6 strategies, such as teach healthy relationship skills here, and engaging influencing adults or peers, disrupt the development pathway towards partner violence, strengthen economic support for families, support survivors to increase safety and lessen harm, create protective environment. This important work, you also highlight approaches, programs, and best evidence. I highlight the teaching healthy relationship to couples. This is the one I will talk later. And also early childhood home visiting programs, such as the Nurse Family Partnership. So I have been very lucky to access this important study, the federal trial. Only 1 publication on their data on intimate partner violence prevention intervention in nurse home visiting program, a randomized clinic trial. I signed a data use agreement and analyzed their data. So this randomized control trial focused on those mothers in NFP program, Nurse Family Partnership program in Oregon, 2005 to 2011, with a U49 award from the Injury Center. And the first 10 low-income mothers were randomized into Group 1 in the standard NFP program, and the Group 2 NFP program augmented with IPV screening, referred to services, and most importantly, the primary prevention through within my reach relationship education curriculum. Scott Denny trained the nurses and to the within my reach curriculum. Also published this important review on the best practice in relationship education focused on intimate relations. This is a 40-year scholar team. Maybe you already know those people. Howard Markman was a dissertation advisor of Scott Denny in 1986 with a dissertation focused on the concept of commitment, how to measure it. And both of them were in Galena Rose's dissertation committee. And you notice Motherwise program, which Galena Rose has secured funding from Administration of Children's Family to work on. Within my reach curriculum has been part of the Prevention Relationship Education Program. The PrEP program in 1993, the study from then already document important prevention effort to reduce, prevent marital distress. In this study, within my reach curriculum include 15 sessions, including the concept of commitment in relationship, sliding versus deciding, which means that Do you plan to move into cohabitative relationship, sexual activity without firmly believe this is a person will bring safe, stable, nurture relationship to you? This is pretty common. Only a small group of people decide that relationship, then move into marriage and having a child. Also, the important components include smart communication, speaker, listener technique, making tough decisions. So the CDC officers tailored this curriculum from group setting to one-on-one setting. I will skip this detail for this trial and my data analysis. So in the first project, we focus on preventing perinatal adolescent dating violence, looking at those 63 teen mothers, only age 15 to 17 years old. Those teen mothers are critically vulnerable, yet underserved. In the United States in 2019, those mothers 15 to 17 years old delivered 40,000 live births. They need a vision of commitment early on to prevent dating violence. One solution is to strengthen social bonds and commitment through the relationship education curriculum explored around in early home visiting. So home visiting programs are critical, but underutilized to prevent perinatal adolescent dating violence, to foster safe, stable, nurturing relationship environment. For example, 3 trials focused on preventing IPV in home visiting settings. All didn't analyze those teen mothers separately. Only the federal trial includes relationship education. The key component is in the relationship education, as I explained earlier, include components on concept of commitment, skills for future-oriented decision. In this way, to provide training on those important concepts and the skill set, and in order to disrupt the path from relationship instability to perinatal adolescent dating violence. We analyzed the data, and those 63 teen mothers, majority of them were Hispanic mothers born in other countries. We found the intervention effect at 1-year follow-up were significant, but not a 2-year follow-up. This is a mediation analysis. We didn't find a significant mediation effect of commitment and relationship stability. So we learned
To let you know, there's about 3 minutes left.
Thank you.
Thank
So
you.
this study, we learned the importance to design new study and to design study include components to engage fathers and enhance co-parenting, because enhanced co-parenting engage another part of the intimate relationship was evaluated in this data study from Central Texas. Specifically, they include last note, another relationship education curriculum to teen mothers, and also family foundation include key components to engaging fathers, enhance co-parenting skills. Now I would skip the second project, focusing on half those mothers, Latinx mothers. But I want to draw your attention to the resilience was and acculturation stress, all important for those particular high-risk groups, those Latinx immigrant mothers. So I will skip this detail, focus on the future study plan. As I explained, we need more studies think about commitment, informal control of resilient families. We need to better improve the program effectiveness to prevent intimate partner violence, such as integrating relationship education, engage fathers, and enhance co-parenting skills in home visiting setting or prenatal care setting. We need to consider, I like to work on this to address the gap on neglected pediatric community intervention and bonding to effectively prevent child maltreatment, especially in Colorado. We want to have more data to design violence-related maternal early warning systems and reduce maternal morbidity and mortality, address intimate partner violence, firearm use, and self-harm ideation. So I'd like to acknowledge those mentors, federal officers, and the funding support. There's a select reference. Thank you for having me. I would like to learn your questions, comments, and suggestions. Thank you.
Many thanks, Dr. Lee, for joining us and for your very informative presentation. It's obviously a very important area of work, and I don't see any questions in the chat. We have time for one or two. And if I don't see something appear, we will just wrap up our summit meeting for the week and remind everyone that the recordings will be available on our website shortly. Thank you again for your presentation, Dr. Lee and Megan, and to all of you for joining us. Thank you all. Take care.